Welcome to the webinar tonight. I think you all know I'm PK and this is Riley. If you're new to WhiteCap, have never been to WhiteCap, we teamed up with a company from Busan, Korea about 6 months ago. This is a company that has designed for the last 5 years prior to that a digital workflow where you can go from A to Z in no time at all. In fact, all in one appointment if things are just right. We just wanted to give you an update on what we feel is our experience with the DIOnavi system, and are appreciative of your time tonight. We know your time is valuable. I recently looked at a list of those of you who have signed up, and it's a super star list. So we feel like my biggest goal for you is you're not disappointed in anything that your time is spent tonight. And just appreciate you. Hope the new year's going well. Hope your practices are thriving, that your families are healthy and happy. So Riley, you've done as many DIOnavi cases of anyone in America. And that might be that maybe there's not that many people doing them right now because it's so new. But,
no, I'll take that title. It's a good title. I'll take it. Yeah, I'll take it.
So what do you think?
It's been awesome. It's been a really good experience. Their workflow has been really easy to follow. The communication with the lab is much improved to how we were doing it in times past. And the surgery's been awesome. And that's really what matters for me. The clinical application, the surgery's been going really, really well. And so those results have been seen over and over again. And that's why, been so impressed with it.
So what we want to do is we want to jump right into this. We're gonna take the camera off our ugly faces and give you some pertinent stuff to look at.
Well, just so you know, there is a spot on your screen where you can submit questions. So if you want to type any questions as things are going on, we'll see those questions live. However, we'll probably answer the questions at the end. If for some reason you're not able to find that feature, you could text my cell phone, you could call me at the end and we could put you on speakerphone, but we want to make sure that you can ask questions. Depending on how much time we have, we'll try to answer as many as we can. If we can't get them answered tonight, we'll reach out specifically independently and get those all answered. So look for that little question area. It should be on the bottom, Q&A. You can click there and type any questions. We're going to go ahead and switch to a PowerPoint presentation. And in that presentation, we're just going to go through some slides a little bit, and then we'll turn the video on again at the end. So let me switch this over.
And we're just going to make comments along the way pertinent to what we've experienced and how it's going for us. And at the end of this, I'm going to give you, some of you don't have my personal phone number. I'm going to give it to you, and you can just text me, tell me who you are, and we can help. This digital thing is new to the world. It's like a foreign language. It takes time to kind of get your feet under you to get going. But once you do get going, it is the perfect solution that I have been dreaming about for 31 years of doing implants. And it's here, and I'm glad it happened before I run out of gas and die. So anyway.
All right, we're going to get started. If your sound is not on, you haven't heard anything, make sure your sound is on, make sure your mic is muted. And again, you can type questions at the bottom and we'll answer those as we go. We're going to start off with the little testimonial from one of our doctors. This doctor's up in the Northwest. It's been a great doctor. We've loved working with him. I'm going to share his little testimonial video and then we'll talk about some things from there. That'll just kind of get us started. So I'm going to go ahead and play this right here.
Hey there, Dr. Nate Watkins. I'm Family First Dental in Kennewick, Washington. I was asked by Riley to talk to you guys a little bit about the DIOnavi system. We as a practice implemented the DIOnavi system right after it was first introduced by WhiteCap in the fall. Honestly, we were a little skeptical at first. Making a change like that is not an easy task and not an easy decision, particularly for somebody like me that's still fairly new in implant dentistry. I've been placing implants for about 2 years, probably have about 40 or so implants under my belt. So that was not an easy decision, but we trusted PK and Riley and what they were telling us about this system, and we're excited about the prospects of it, particularly the thought of having everything fully guided. We had a cone beam here, we had a digital scanner, so the transition was fairly easy for us. So We jumped in with both feet, and honestly, we haven't looked back. We've been extremely excited about the results that we've seen. I personally have been able to do several guided implant placement in the anterior zone, as well as a couple guided vertical sinus lifts. With regard to the sinus lift, that's been a game changer to be able to have a procedure like that fully guided. Just takes so much of the guesswork and the headache and hassle out of that. Was always really leery to do implant placement, particularly in the anterior in the aesthetic zone, but was able to get surgical protocols and guides produced for those, as well as custom abutments and provisional restorations. And to be able to have a patient walk in with a tooth that's broke or otherwise non-restorable, and be able to walk out with at least a temporary restoration has been phenomenal. Patients were thrilled. It was such a great service to provide for them. Have a couple examples of some images, see if I can show those to you, just what we're able to see. One of these was a lateral incisor, the other was a central, and they turned out great. Haven't restored those yet completely, but we've seen them for a couple post-ops, and things are looking great. The tissue management, to be able to provide those temporary prostheses is really unbelievable. So one of my partners was able to do a guided surgery for a complete prosthesis on the upper arch. I believe 4 or 5 implants were placed, and that was all done guided. And he was ecstatic with the results with that. So it's been a great system for us. We're excited with it. We're excited to see what else we can do with it, what more we can learn, and how we can implement it further in our practice. But anyway, hope that helps. Thanks.
So let me just stop there for a little bit. That was awesome. That is one of our bigger offices up in the Northwest. I went out there and did some personal training with them, and it's awesome to see that the protocols are working well for them, and they're continuing to learn and grow, and we're excited to support them. So I just thought that was a good way to kick this off, let you know that we have a lot of doctors that have adopted the DIO platform, the DIO workflow, and nothing's perfect, but certainly the vast majority have had great recommendations like Nate here is giving. So appreciate Nate giving that. I want to do a few updates about WhiteCap. So we've upgraded and updated a little bit our actual facility here. If you're real familiar with WhiteCap, you know that we used to have those concrete floors everywhere, which we loved. We dropped some new carpet down. We outfitted some of our clinical operatories with new surgical lights, new chairs. So there's been a lot going on at WhiteCap in addition to just a new implant in our drawer. Our facilities look new, updated, and improved. We're really proud of that and grateful for the relationship with DIO that allows us to do that.
Yeah, it's nice. I didn't realize how old I was getting walking on concrete all day long. But those of you guys that have concrete floors or unforgiving surfaces realize your feet and your whole body takes a beating. I like the acoustics better in the office now. We've totally renovated a big network for all the operatories, all 9 or 10 of them. It's makes it fun. Changed out a bunch of lighting, did a bunch of cool stuff. So look, if you guys get in town to ski, come over and bring a PA and we'll look at it and write off the visit on your taxes.
Hopefully we're not recording this. Nate just texted me that did that video. He said he did another one today and it went great. And he said he forgot to mention how he loves how the drill's cut. So Nate, you're listening. There's another shout out for you. So thanks, Nate. Couple more updates. As we have gotten busier and busier with our new workflow, people are doing more implants because it's more predictable. We've had to upgrade our lab. And so we have tripled the amount of people in our surgical guide department. We have doubled our store personnel, and we've added 2 new DIO specific trainers that travel to offices to help you do your first few cases. So if you recently bought some DIO packages from us, make sure you reach out and let's get those trainers in your offices for your first few cases. That's their sole purpose. They are there to help you do your first few cases.
If you're just a non-DIOnavi user, but just curious, you get us the digital criteria that we require, and we will do a test drive with you. And I'm putting my money where my mouth is and saying, that guide and the implant, 1 or 2. I'm not doing full mouth reconstruction with this offer, but basically we're saying we'll come to your office and we'll bring the kits, we'll bring everything you need and let you take it for a test drive. I think it would be worthy of the effort to take me up on that offer, and I hope that you do, and I look forward to, if I can be there personally, I'll do that.
So here's kind of, I think, what we want to update you on in terms of clinical updates and changes with DIO. First, I want to talk about the DIOnavi website and this new Smart Navi module. We'll probably spend a bulk of time with that. I want to talk about the importance of diagnostic accuracy, anatomical abutments, the UV activator and UV active implants. Want to review the guides, surgery protocol, immediate load cases, talk about case packaging, and then a course that's being offered in Korea. So that's kind of a little outline what we're going to go through. Let's jump right in. So if you are familiar with DIOnavi and you've already submitted some cases, this might look familiar to you. If you're new to it or have never done it, they just released a brand new feature in their website where you can actually help manipulate the surgical plan a little bit buccal, a little bit lingual, wherever you want to go to get it just perfect. And so what you're seeing here, I'm going to play this video. This is what happens when you log in, you check the status of your account after it says a case has been planned. This is what you're going to go in and look at to determine if the implant is in the position you want. So you're seeing all of these different perspectives, the XYZ axis here. I'm going to play this video and you'll see kind of what this looks like. This indicates it's number 22 implant. These 3 tiles are the different fields of view. And you can look at the implant and grab, and you'll see the red box move with the implant. And that is showing the planners where you would prefer the implant to be.
What I think is unique about this is there's a silhouette. You can move the implant, but the original placement is still there. You don't lose it. That's really compelling.
Here you're seeing an implant being switched to a whole different size. So instead of writing to the lab, hey, I want a different size implant, you actually can just do it right here on the screen and see how it looks. This is going to help streamline the communication for us, the doctor, and the lab to get the plan exactly where you want it in a quick fashion. So we're not waiting, postponing surgery, rescheduling surgery because planning's taking too long. This has been in beta test a little bit. It just got released a couple of weeks ago. We're still making some improvements, but this is out now. So if you're a DIO customer, when you log in, confirm cases, you'll see this feature now. You're more than welcome to still type your instructions of how you want the case modified, but you're also welcome to now manually do it yourself, and they will see that physical change of location.
I don't think it makes any sense to do all this heavy lifting by yourself. As a general dentist, we're too busy. We need to outsource this with the digital criteria required and let the heavy lifting be done. Honestly, you're going to do very, very little adjustments to anything because these people that do that are crazy cool and good at it. So that's what I appreciate about it. And I do as many implants as anybody, and it takes time to manage these cases. And I'm finding I'm spending way less time managing it. They're coming predictable. They're landing on their feet. And I think this is a really nice addition. And there's a couple other things we'll show you that are very cool.
Some of you have asked if Jim is still in the lab. Jim is certainly in the lab. He is heading our surgical guide department. We just happen to have a lot of helpers around him right now. The helpers around him are new to WhiteCap, but some of them have planned over 20,000 cases. So they are very, very planned, very experienced with planning. But Jim is still there. Jim is still your liaison. Jim is a vital part. I know a lot of you that work with us love Jim as we do, and he's still there playing a very big role. This next feature I'm going to show you is called Smart Navi. This might be one of the coolest things I've ever seen. This is all designed from DIO. This is a project they've had going on the last several months, and it just got out of beta testing. So
the coolest thing you've ever seen.
You
are the biggest dental nerd I'm sitting next to.
This is the coolest thing.
The rest of the dental nerds are watching this on a Wednesday night
here's
after a long day.
Why this is so cool. And maybe this is selfish. I'm going to show you a simulation of the surgery of your exact case that tells you what drill to use, what sequence to use, tips and tricks of each drill, and clinical videos of each drill, which are going to answer your questions. So selfishly, I think it's the coolest thing ever, because you guys on the other end of this webinar might not need to call me as often and ask questions.
Okay.
Because
this
everything
is the coolest.
This is the coolest thing ever.
Okay.
See,
now,
this is the coolest thing ever.
What is so cool, in addition to the cool other things, is it tells you what density of bone, because the software used does density analysis. Because we're talking about primary
PK's
stability.
getting excited. He's skipping ahead.
I am
let me
excited.
start right here.
Riley, I hate it when you're right. I'll be quiet.
Let me show you what you're seeing here. On the top right, I cut it off, but there would be a thing that says starts simulation. But what you're seeing here is a patient name. They're showing you what platform of implant is being placed, a narrow, a regular, or a wide, and what surgical kits are required for this particular case. So this screen here is going to change for every patient. If you're doing a sinus lift on a narrow platform, let's say implant, you would have all of the different kits listed right here that are required, and it would be different and unique here. I'm going to start the video, and then I'm going to pause it multiple times to highlight some features that just kind of go by quickly.
And I'll try not to be excited.
No, PK, he'll try not, but we'll see what happens.
Mm-hmm.
So we're playing here. There, I'm just highlighting patient name. Here's the surgical kits that are being used. And then I'm going to go ahead and say start simulation. It tells me what implants, number 6 and 11. Right here, I'm going to pause it. This tells me that I have an implant plan for number 6 and number 11. It has the implant sizes. And then it also shows the D1, D2, D3. The software has already determined that your implant is in a D3 bone.
They already know that, Riley. I told them.
Yeah, PK jumped the gun and told you that. Let's say, so what that means though, because it's selected D3, the protocol you're about to simulate is a D3 protocol. If you say, no, I want to see the D1 protocol, you would simply click the D1 here, and everything in the next screen would be different for D1 protocol. So you're going to click both teeth. You're going to select, well, it already pre-selects your density. If you want to override it your own way, then you can click a different one. Then you're going to click next and wait till you see what happens. Now we show up to the simulation, and this simulation has a lot going on. So I want to highlight a couple of things. The screenshots you're seeing on the right are the exact screenshots of your exact case. So this is not a simulation that is generic in terms of the pictures up here. This is specifically your case. You're seeing the drills kind of in a carousel fashion down here in the bottom. And then the player, skip, pause, controls on the right. The coolest feature is over here on the left. I'm going to go ahead and play the video and highlight these things as we go. So on the left, we have the sequence of drills that you're going to use with their serial numbers or lot numbers. We have a clinical video of the exact drill in the carousel. So if I go to the next drill, a clinical video of how to use that drill is actually being shown. And then here's tips and tricks and insight for each drill in the carousel. So if you're new to DIOnavi, the thought is you can come in here, and if you have a question about how to use the tissue punch, the bone flattening drill, the abutment profiler drill, well, there's a video that shows you how to do it. There's words and x-rays and pictures that explain how to use it. I'm not saying you can't call me anytime, but this I think will alleviate a lot of questions, and this is on demand. If you can't get a hold of me, if you got internet, you go to the website, click on your case, hit simulation, and you're right here. I'm going to go ahead and let it play a few drills, and so I'm going to let it go. So here it's saying you're going to put the guide on.
Drill. Bone flattening drill.
Tells you what
at
drill
100 RPM.
What speed.
On 11.
And what site.
I bet that voice actor is from Texas. Did you recognize the accent?
Definitely from
Drill
Texas.
tube.
Yes.
Install.
Tells you to put the drill tube in.
Drill. Initial drill. 2.0 millimeter diameter
And
by 5.0 millimeters at 100 RPM on 11.
So again, you could have clicked those little boxes on the left if you had a question about what does this drill do? How do I use it? What are some tips and tricks? I want to see a clinical video of it. That's all right there. Now I skipped the video ahead to the very final implant placement. We're not saying you drill with a pilot and then you put the implant in, but I figured repeating every drill might not be helpful. So now we're
Place
skipping to place
by 13 millimeters to the second marked line, 4.0 millimeter diameter, implant fixture, regular non-stopper implant connector.
Now, what I think is exciting at this point, the DIOnavi system accommodates for a custom abutment to go on right now. So there's this insertion tool, and everything has guides that make the rotational alignment perfect for the next step is putting in the custom abutment and then the PMMA temporary.
Yeah, the guide thinks of everything from A to Z. It's going to take care of all that. Some guides you have to figure out that rotational timing yourself, not with DIO. They do that for you, and the guide is all hardwired in a way that you know how that works. So this simulation, I think, is really helpful to someone that's new to the system, new to surgery, wants to review it. Maybe staff members want to review it to get more familiar with it. I think this is going to be amazing. On demand, it shows every drill. What's also very cool, let's say you're doing 5 implants on an upper arch. If you select all 5 and then play the video, it will tell you the most efficient way of using your drills without loading them and unloading them twice. So they have some doctors that actually play this video during surgery, so you know exactly the sequence to use it in a very efficient manner. You can use it however you want, but it's a very cool tool that I think is going to answer a lot of questions, leave everyone well informed.
I frequently use YouTube interoperatively to make sure I'm doing it right.
Absolutely.
Yeah,
PK,
so this is not new for me.
This
I've been doing for 31 years. That YouTube, you could get a literal degree.
Yeah.
But the confidence the patient has in you when you turn on the YouTube and look at it first and say, okay, let's do it. This will be my first. Well, it's remarkable.
It is. Well, they see you do exactly what the video did, and that reinforces that confidence.
Yeah, I'm with you.
Absolutely.
You are definitely a dental nerd.
Okay, moving on. So moving on, diagnostic accuracy. So real quick, one slide on this. Here is a clinical update and a clinical frustration for me. DIOnavi requires extremely accurate diagnostics because their guides fit insanely tight. In a good way, not tight like they're too tight fitting, but the accuracy when the guide is seated properly is phenomenal, but not if we don't give them the right diagnostics. We have gone through a learning curve at WhiteCap, and we have found out that some of the mediocre diagnostics are simply not up to par for DIO to shine with its accuracy. And so this is actually a case that my office submitted, I'm embarrassed to say, and an assistant sent this over and it got rejected. And so just a reminder, I know that we have a higher turnback rate than we've ever had with some of our doctors sending us files. And that's because we're asking for even more accurate diagnostics so we can give you the full octane of DIOnavi. And so realize we're not trying to nitpick, we're trying to give you a really quality product, and we just want to highlight the importance of really good diagnostics. Here's one tip and trick. When you take a digital scan, please look at it in a monochromatic phase. I know these intraoral scanners love to come out in their true color and 3D definition color and all these funny little things. But in my opinion, for analyzing the accuracy of your impression, your digital impression, a stone color, a monochromatic image is the most important. And look on the occlusal and incisal edges. That is where you're not gonna that's where you're gonna have errors and overlapping issues. So just double check that, make sure you create a really accurate impression. That's going to get you a really accurate guide.
But you know, in a way, it's embarrassing it came from your office. I have done the same thing, not just once, but several times. And it just alerted me that what I was asking my dental assistants to do, they weren't doing it correctly. So then we remediated them in some technique acquisition techniques. And all of a sudden we're in a different orbit of accuracy for everything that from that day forward.
Yeah, it's just technique sensitive. You just need to know the right technique. We're going to try to move along a little bit. We have some great stuff to share, but we don't want to talk too much on one topic. So here's the anatomic abutment lineup. As you may have heard, DIO has these anatomical averaged custom abutments in a library that we are calling anatomic abutments. So they are not custom abutments. They are not stock abutments. We consider them a hybrid of that. Currently, we have 200 that are FDA now approved now, and we are currently stocking these in the lab. We're going to start using these quite a bit. What is unique with these are a scan body as well as a full contour abutment.
So basically, what I'm excited about with my cases is I'm getting this custom abutment, but I'm not taking it out ever. I think the hemidesmosonal attachments, fibrotic adhesions, or whatever you want to call this, is ridiculous with standard protocol, taking stuff out, putting it in, taking it out, putting it in, getting ready for the final. So I'm not taking it out anymore. From the time of surgery with fresh reedy pegs there and a clean, sterile titanium, I'm optimizing this. It is my personal opinion that that is a major reason, etiologic reason for peri-implantitis, but it's just my opinion.
So again, those anatomical abutments can go in the day of surgery or at uncovery if you wanted. You could put a temp, you could shape tissues. You could take the temporary off and just scan the abutment. It does not need to be removed and take a fixture level impression. You will scan the anatomical abutment. We at WhiteCap Lab have those geometries, and that is your scan body. So that abutment never needs to come out. We will mill your crown. We can put a screw access hole on top, and it can still be screw retained. But it goes in once, stays in once. It's the one abutment, one time philosophy. Now, is that going to work every time? No, but when it does work, I think that's a great clinical advantage, and we're glad that we have 200 SKUs now that are FDA approved.
Now, one of the other things is a lot of times the PMMA temporary obviously is a prototype of what the crown could look like if you copied those geometries, and many single implants, the PMMA is just right. So I recognize at a post-op that it's perfect, the contacts are great, the color match is great. I just say to the patient, okay, I'll have the crown made without touching them. Then when they come back, I take the temp off, clean up the residual cement, and cement on the permanent, then clean up the cement because it's easy, and peri-implantitis cement overflow is not going to be an issue. Then put your Teflon in, then go ahead and do your composite to fill your access opening, and you haven't ever finished taking in a final impression. The final impression happened with your digital planning before you did the surgery. Yeah. And some of you guys, you know, have to do expeditious billing, and sometimes you could, I mean, you definitely could legally bill for the final restoration the day you put it in, if the insurance allotment was available.
All right, so that's anatomic abutment update. I want to talk real quick about the UV activator and the UV active implant. Real quick, what DIO has made is a UV activated implant where UV light is used in a special capsule with special gases. And by doing that, it removes, by activating it with UV light, it's removing organic compounds on the surface of the implant that do not allow it to be as bioactive and as compatible in a hydrophilic manner. And so I want to show you a little bit what this looks like. So this implant comes in a little container. It is actually activated on this machine right here. This is called the UV activator. And this UV activator is something that you lease. And when you lease it, it actually will activate that surface, removing those organic compounds. I'm just reading something here that the activator just won one of the premium design awards in the medicine and health category from the World Design Organization. And so that's pretty awesome. And really, really proud of this technology. So you're seeing the capsule go in, the capsule come out, now it's activated. So you'll prepare the osteotomy, activate the implant, put it right in. I just wanted to show you that video. Let me show you a couple videos that highlight what's going on with the surface. On the right is, I think I can just name the brands.
That's a hyacinth. That's a hyacinth hydrophilic.
This is their super hydrophilic surface on the right. On the left is the Straumann super hydrophilic surface. And in the middle is the DIO UV activated implant. Check this out.
After you see this movie, you're going to rename these hydrophilic as hydrophilic knot, Straumann, hyacinth. Hydrophilicity is at a new level.
So look at that.
If that doesn't blow your mind, you're not a dental nerd. I encourage you to become one. And if you're not one, fake it till you make it.
So check this out. So here's another video. You're seeing a normal surface, and then we UV activate the surface. So here's the normal surface, and that video on the bottom is playing still. It goes on for 2 minutes. That droplet never incorporates onto the surface. Here is the same implant UV activated. It's remarkable. So creating that hydrophilic surface, the cells and the blood will adhere to the surface of the implant quicker, and by doing such, we have improved, faster healing.
So basically, in a nutshell, you're getting optimized blood to implant initial, more abundant wettability of the implant, which translates into what's super important is bone implant contact, the BIC. And it's all about it. So a standard implant that has had hydrocarbons collecting on it just because of the nature of oxygen being exposed to it, that just happens through oxidation. That's just what happens. With this implant that's been manufactured and never exposed to oxygen, but kept in a non-oxygenated capsule with a special glass capsule to allow the UV to happen, we are seeing some. I'll tell you a quick story. I know Riley wants me to shut up, but I'm going to tell it anyway. Here's the deal. Right before last year, in a couple of months before Christmas, young gal comes in from Utah State. I put in her missing laterals two implants, and then she comes in just before Christmas. I promised her that I could rush some lab work and give her her teeth. Number 10 implant failed. I uncovered 7. It was ISQ'd at 70 and 75. I ISQ'd the other side, and it was 52 and 58. I immediately PARQ'd with the patient, got permission, took the implant out. It's got just a big mess in there. I thought, well, okay, let's use a UV activated implant, activated it, put it in. Now she comes back 29 days later, and I kid you not, because I promised her that, because I overpromise things all the time. I'm working on it. So basically she comes back, I uncover that side, and I ISQ it 28 days later. I can't believe it myself. 72, 71. ISQ. I took final impressions, and I'm back on the racetrack with getting this case, you know, complete and done. So I have a personal clinical conviction of the efficacy of this new technology. I personally didn't understand it when we first made this partnership. I flew down to UCLA and I met with a Dr. Ogawa, who was the world leader in photofunctionalization, and he helped me understand all that it's real, that it's not hocus pocus. We left him with one of our machines. 6 weeks later, he blew our mind with his results. Are saying, you guys have something nobody on planet Earth has. And it's something that many of you that are listening tonight are using it. Those of you who aren't currently using it, let's talk and get you set up if you want to for some things. When would you use it? Immediate extractions, complex medical histories, or protoplasm.
Okay, so that's the UV active. We've had similar stories in my practice where failed implants, we can get back on the timeline the patient wants by putting in a UV active implant.
Did I just hear that you've admitted you actually have failures in your life, Riley?
Well, just one. It was the first one I've ever, it was tough. I was depressed for a week, but I got over it.
Good.
So just one. I read about the other ones. Real quick, let's talk about guided surgery protocols. If you're not familiar with DIOnavi, it is a slow drilling 100 RPM with no water, with subsequent diameter and length incremental changes and increases. So we start with a 2.0 pilot drill. After a tissue punch and a bone flattening, we go down a certain length, then a little bit more length. We then open up the diameter to a 2.7. We go down a little length, a little bit more, and a little bit more. By following this very incremental increase strategy, we are able to form an extremely accurate osteotomy that is very complementary to our digital plan. And that is what allows us to put in custom abutments and immediate temps that fit with little or no adjustment. This is a different approach, slow drilling, more drilling with incremental steps in length. And by doing such, the accuracy is increased. You're not seeing anyone else doing this, but you're also not seeing the accuracy that DIO can give.
But basically, the reason that they have gone to this extent is they're not just accepting the fact you're going to digitally insert an implant. They are saying, I'm going to perfectly insert an implant and its rotation so it can immediately receive a custom abutment and a PMMA temporary. I was doing some mentoring out in Virginia 3 weeks ago, and we did 6 or 7 on the top and 6 on the bottom, custom abutments, roundhouse PMAs, fits like a glove. Crazy, 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 exciting stuff.
So again, we could talk all day about just this paper right here, but this is the drilling protocol. If you're not familiar with these, reach out. The trainers or PK and I can help with this. The one clinical pearl I want to update you with here, if you've been doing DIO implants and you've done more than 15 or 20, reach out to us. We want to start sending you a few new fixture drivers at the very end. We have found that the very apical end that inserts in the implant will wear with time, causing it to jump inside the hex of the implant. And so we want to send you a bunch of those for free. We're going to be proactively getting those out to you if you've already bought DIO, but that's a little update for you. If you're seeing that, we have noticed that. Because of that, we're making some changes and we're going to get you some new parts and pieces, no cost, obviously.
And I would also say, Riley, if they use their loops and light and look into the capsule and put that insertion tool directly into the implant, a lot of it you're used to just kind of stabbing it, and it's mucking up that insertion tool as well.
Yeah.
So I found that personally is making a difference for me.
So that's some of the guided surgery protocol things. I want to go through just a couple of more thoughts here. One thing we love with DIO is just the accuracy. Their drill tube with your initial drill is 8 millimeters long. With that increased length, the drill is much more accurate. And I'm finding that more accurate drill is keeping everything much more predictable in terms of the end result. So if you do some math here, if you're able to move, let's say 5 degrees on a 25 millimeter or 23 millimeter drill, which would be a 13 millimeter implant, you would actually be 2 millimeters off on the apex of where that implant lands. That could be out the buccal plate, out the lingual. That is a big mess. And I've seen that with other guide companies because 5 degrees is not a whole lot, but their fit and finish on these is phenomenal. So the fit they have right here in the middle, their tube that initially goes in is 0.01 millimeter contact space in between the surgical guide sleeve and the drill tube itself. That equates to 0.14 degrees off. That's extremely accurate.
It's 80% smaller than a 1 millimeter off.
It's insane.
Yeah.
Now, what does that do for you? That provides dual contact. By using a tube initially, you're going to get down into bone. You're going to create an osteotomy in bone, and then your keyless drills go in and their cutting edge is able to get into the bone, and then the guide is meeting the tube surface of the drill, providing double contact. So their drill protocol is a tube system with initial drills and then tubeless or keyless on the other drills, but they've thoughtfully considered it to make sure you have dual contact when drilling. That is the downside to a keyless system, is you do not have dual contact. And then this is how you irrigate in between drills. So if you do not have these tips in your office and you're a DIO customer, reach out. We need to get you these irrigation tips because this is really important. In between drills, when you're switching out the drill, this goes all the way down in the osteotomy and irrigates and cools the bone.
We suggest never bearing down on the waterless drill, going slow more than 10 consecutive seconds. If that can't be facilitated to get to the depth, come out, irrigate, go back in, not to exceed 10 seconds. It's a genius system. We're really loving it.
Let me skip through a little bit of this and show you a case real quick. We probably have maybe 7-8 more minutes and then we'll take questions. Here's a number 10 case. The guide is seated. They fit like a glove. You see a tissue punch being used. It's the only tissue punch I've used. You run it and it actually sucks the tissue up in the tissue punch. You can see it a little bit just sitting right there. and it has a little wedge in there, so it actually will tissue punch and then peel off the tissue off the bone. Very, very clever.
Now, I just want to mention a little pearl. Those of you who are DIOnavi users, at this moment, come out, take your straw suction, stick it in the end that cut the tissue, and it'll suck the tissue out. Otherwise, your dental assistant may not find it. They'll autoclave it. Now you have petrified, sterile tissue remains.
Oh, that's the worst.
Yeah,
I hate that. That's the worst.
Well, it makes me itch.
Yeah. So there's the tissue punch again. You see that tissue in there. Really clever. Here's the bone flattening drill. Here's the pilot drill with the key now going in. So this tube goes all the way in. This is a very long one because this is a very narrow ridge. So this is for extreme accuracy. Just like your other guides, you put the drill in all the way down to the depth stop. Constant push, no more than 10 seconds with irrigation in between.
Never run your burr until you are in through the sleeve and touching bone. That creates undue heat.
So right here, this drill on the left, you're gonna push that in the sleeve and push it down until you get an apical stop on the drill on the top of the bone. And then and only then do you push the pedal and run the drill. Otherwise, you'll create friction between the metal sleeve and the drill itself. So there it is, making the osteotomy a little bigger. I'm jumping through this a little bit. This is a very unique tool that DIO's come out with. You run this circumferentially around the guide sleeve, creating a profile at the crestal bone so that there will not be any bone that holds up the seat of your custom abutment. This is perhaps the most important part for the restorative aspect of the surgery, because if you don't remove that crestal bone, you're gonna have a hard time seating the abutment. You'll get the implant in 2 minutes and then you'll fight the abutment for 20 minutes. I've read about it. This tool here eliminates that problem. So then the implant can go in. On the right, it's a little blurry, but there's my custom abutment on a seating jig. I seat the jig in the mouth, not letting that wing helps it not rotate around the profile of that canine. And then I go ahead and seat the PMMA. There was 0 adjustment done to proximal contacts or fit of margin around the abutment.
Now, it's kind of interesting. You think about it, when you have your custom abutment on, you may not know it because we didn't show you the picture. There's a hole in the lingual where you can screw your screw in, but you hold the temporary where you want it or where it's supposed to be, and you can be certain you can get to 30 Newton centimeters because you're not going to move the implant, because the implant can't move because of the index of the abutment and the implant. And I found that to be very clever and very useful for my practice.
This patient loves this though. They come in, they leave with a tooth like that. When you go to take a final impression, you just pull off that temporary. If it's an anatomical abutment, you just scan the abutment, send it to the lab, and we send you back your crown. I mean, it's a clever, clever workflow. I love this case because this patient's girlfriend had the same thing done by a different office, and she's 3 months through treatment and still has a flipper. This guy came to me, he left with a tooth the same day.
I think we should all raise our right hand and pledge never to use a flipper again.
There may be a time and place, but this is certainly better. This
Yes.
is certainly better. The girlfriend is wondering why she went to her dentist. The boyfriend is saying this is worth every penny. Real quick, DIO also has a guided protocol for sinus lift surgery. This is what the protocol looks like. In the spirit of time, I'm going to skip this and just show you some results by using the guide here and a safe protocol of doing a crestal bump. This is a case I did. It was about 12-minute surgery, putting 2 implants in and a crestal bump that was 9 millimeters of lift on a crestal approach with a guided surgery. This is another case I did. You can see it drilled right to the membrane. I went ahead and took out the guide, and I took a couple photos because it looks so cool finding the Schneiderian membrane right there.
Say Schneiderian again.
Schneiderian membrane.
That's great.
And that's 9 millimeters of lift right there on a crestal approach with a guided technique. I mean, your biggest concern with the crestal approach is where's the membrane? Where am I? How thick is the bone still? Well, the guide puts you right to it in incremental steps. Really, really clever.
But that picture is a little weird. That's a bunch of bone chips around the tissue. It's flapless. Or is this a flap?
This is a flap here. This is the case I did.
So that's bone. Okay.
Yeah.
But frequently you're doing flapless, complete guided vertical sinus augmentation. And you'll see a case in just a minute where you frequently can put on a custom abutment and a temp, even with that, based upon density analysis that DIOnavi provides us.
So really cool to have a guide that can get you to that result. Who wouldn't want that? Super predictable. Really quick, you know this if you're a WhiteCap customer, we can send you your implant, your guide, your abutment, your temporary, all the drilling reports, all the paperwork in one box. If that's not cool, you haven't dealt with the inventory issues of implantology. I mean, that is amazing right there. Your staff will love you if you can just get a case that shows up in a box versus trying to put it all together and then having inventory issues. That's a picture of a case over in my office, and that is amazing. Have it show up just like that. Let me show you a couple of videos as we wrap this up. This was PK mentoring the other day in northern Utah.
I'm with Dr. Dustin Goodwin. We're here in Tremonton, Utah. We just did a guided surgery on a number 3 that we did totally flapless. We lifted the sinus. We did it all digital. We put a temporary crown and a custom abutment on at the same time. You'd never done that before. You made it look easy. How did it go for you?
It was easy. With the guide, it's predictable. Everything's right where it's supposed to be. It was pretty slick.
I would say we were, about a half an hour or so, start to finish, and that worked well. So all of the design was done ahead of time, and we knew precisely where the implant was going. We knew the densities of the bone around it, which gave us the confidence to know that we could primarily load it through an immediate load, which that custom abutment and temporary went in seamlessly. It was really gratifying to see. And anyway, very, very exciting.
Yeah,
Thanks for letting me be here.
I'd just like to say that, I didn't sleep well last night. I was nervous about this, but it went smooth. It's just something I feel like I can do.
Yeah.
I'm guided through it. It's awesome.
That's awesome. I love that. Lost sleep over it, and then you show up and do the case and realize it was no big deal. I mean, isn't that the point of the technology, to leverage it so that some of these fears aren't really problems that we need to deal with? We can just do better with our technology. Here's another video.
I'm Dr. Connor Thompson. I practice here in Central Utah in Ephraim at Ephraim Family Dental with my brother. The two of us have been WhiteCap alumni since about 2012. We've been placing implants since about 2010, and most of our implants that we place have always, since then, been surgically guided. Recently, with the merger with DIOnavi, we feel like there's been many improvements made at WhiteCap in the digital workflow. It's so easy to take a CT, take a intraoral scan, STL file format, send it to the lab, have them plan it, have them look at it and all of the parameters, send you an email seeing if you like it or what you dislike, and then have them mail it or print it and then send it back to you in the mail. That whole process takes about 5 or 10 minutes. My brother and I are CEREC doctors as well. We have mill units. We have a couple of different mill units and a couple different CEREC acquisition units in our office. Dentsply Sirona really pushes all of their dentists to try and mill their own guides. We have chosen not to do that because of the ease and the simplicity in the digital workflow that DIOnavi provides. We save ourselves probably 30 to 45 minutes per case in planning and getting our surgical guide fabricated rather than us having to mill those guides ourselves. If you have any questions about the digital workflow that DIOnavi provides, please don't hesitate to get in touch with us through WhiteCap, or obviously talk to PK and Riley. It's been a very rewarding transfer over to this new DIOnavi system.
Wow, that sounded like a fabulous commercial.
We didn't even pay him.
No.
I mean, we thought about it, but he said it without paying him. So we just thought we'd go for it.
Well, because he's using the digital workflow, he has more money than he needs, and he didn't need the money that we were offering to pay for that commercial he just did.
Gosh, that's profound. I didn't even think about that.
Well, think about things, Riley.
Oh my
Think
gosh.
out of the box.
Oh
man.
my gosh.
I'm Dr.
Okay. Okay, real quick, wrapping up. There is an awesome course going on in Korea in September. Why is it awesome? Well,
Because I'm speaking.
yeah, and I'm speaking. So
I'm speaking in Korean, but they will translate it in English for you.
I will be
Please
speaking.
come.
It's confusing. I'm speaking in German, but they'll be translating it to English and Korean. So, you know,
Me not speak Deutsch.
no, 9.
No, yeah.
So there's an early bird special. It's $1,150. That is, I think we decided that is until June 1st. That includes a couple nights at a 5-star hotel with breakfast and lunch, airport, hotel, transport, and you get to hang out with PK and I in Korea, which is really priceless. So that $1,100 is a steal.
You could never put a price on it.
You couldn't. I mean,
Yeah.
if you did, it would be 7 figures. So that's, that's a good deal, $1,150. So come to that with us. PK and I are going to be there. I believe we are both bringing our spouses. So if you want to make more of a trip out of it, it's a great way to get to Korea.
And if there's a bunch of you, we'll arrange, I don't know what I'm talking about, but we'll get someone to help us do a tour of, South Korea.
Yeah,
And
there's hundreds of people at this conference. I believe it's like 800 doctors attend, if I have my numbers right. But we get enough WhiteCap guys, we will have a little WhiteCap event and a little day trip or something out there. So we'll make something fun out of it. So save those days, September 18 and 19 this year. Busan, Korea. PK and I went there last year, about the same time, actually.
Mhm.
It is a beautiful city. Nothing like I thought. It's well worth it. So I would check that out. I'm going to skip over this. We have some special offers on implants. If you're not a DIO customer, let's make it happen, and let's make it happen in a way that makes sense for you. We want to thank you for your time. We took a lot more time than we intended, but
probably my fault, but I'm not apologizing.
no, it's all good. So, okay, we have a few questions. I think I'll answer 1 or 2 of them. Number 1, there was a comment made. I think we should answer that. You both look fabulous, from Mike Pratt. I couldn't agree more. I don't know if I have much to say other than I agree. Anything from you, Dad?
Yeah, I think Michael's a suck up.
Yeah, Mike, he's just genius. So, Nate, I think we answered your question. You talked about, I found separating the implant connector from the implant replacement difficult. Oh, I see what you're saying. So you're saying after you place the implant, it's hard to get it out. Absolutely it is. It's all a tight fit.
That's where rongiers come in.
That's the
The
rongier.
only thing that I've regretted using the rongier on was I didn't have any money, no medical insurance. It was Riley's circumcision. It went horrible.
It was a bad day for me. I don't remember it, but
Yeah.
it wasn't the best day.
So Nate, use the rongier or something equivalent and keep your hand on the guide and just wiggle it with an apical or a coronal position or pressure. Be careful when it comes out. It's quite abrupt. You'll smack the opposing arch, but it's good for your restorative business.
Brad has a great question. He talks about, can you go over how to cement on the anatomical abutment? Isn't it more likely you're going to miss some cement, cause periimplantitis? Absolutely. Here's a trick with that. Anytime you're creating a screw retained restoration, but you're cementing, you are going to, here's what I like to do. Take a cotton applicator, squirt a bunch of bite registration inside the crown before you cement, and shove the cotton applicator in there, creating a seating jig. And when you cement, you will push it on that seating jig, getting all the excess cement out, and then go and seat in the actual mouth on the abutment.
Let me tell you how to do it right. Just take your cement, push it onto the abutment, take it off, take a micro brush and clean it up, and then push it back on. You'll be fine. Don't listen to Riley. That was nuts. I didn't even understand what he said. I'm sure, Brad, you're rolling your eyes backwards. But the other thing you might want to consider is to take a alcohol 2x2 and sterilize the abutment, because humans have touched it. Get rid of any oils.
Well, the abutment's already in, we're saying,
Oh,
anatomical.
Okay. But
Don't even listen to PK, he doesn't know what he's talking about.
actually, I don't. I was going down the wrong trail. Sorry, I was getting tired.
But no,
Forget that. But
you're gonna
the
see-
first thing that I said was better than the last thing Riley said.
essentially my method is creating that fake abutment that you can do the exact same thing, but out of the mouth, but often in the mouth. Seat it once, take it out. You've got a minute,
Yeah,
clean up the cement, and
Yeah.
then push it right back on.
that's what
there.
I just said.
Well, I'm saying I did the same thing extra orally.
Yeah, but you used one mixing tip. You used a bunch of.
Well, you
Bite
buy the
Red.
mixing tips. So
Well, I
who-
know. But
Yeah.
these guys are frugal.
All right. Fair
That's
enough.
that's how they can afford
enough.
to hang out with. others.
So Flint is asking, is the Korea trip replacing the summit? It is not replacing the summit. We want to have extra fun with you in the spring. And so come hang out both. Flint, you better come to Korea or I'll be disappointed.
I think you should all bring your wives, and those of you who are crazy Mormons, you should go do some church stuff over there.
Seems like not all digital scanners are created equal, and DIO has their favorites. Any suggestion from Corbin Matthews? So yeah, they are not created equal. You want a very accurate impression. I have found the Carestream to be very accurate. I have found the 3Shape to be very accurate. I have found the Medit to be very accurate. And I have found the brand new Sirona Prime Scan to be very accurate. If you do not have one of those, I'm afraid I would put you on the Riley naughty list. I hate to say it, but those 4 are the ones we have the most success with.
So they will not receive a scanner for Christmas.
Yeah, they will not be receiving. That's right.
Because their decision-making in the past has been a little bit questionable.
Yes, I would agree.
Okay.
I would agree. One more question about posterior implants with guides. It's hard sometimes with limited mouth opening. This will be our last question. Absolutely. I would say second molars. Sometimes it's very, very difficult to use a guide. First molars can be difficult. It's based on the patient, obviously. What's nice with DIO is they have these very short 5mm drills to get you started. And then from there, you're using the built-in keyless drill. And I find that makes it easier. If worst case scenario, you can't get any more than the 5mm pilot drill, sometimes that's all you can do. I'll take off the guide and then have to freehand the rest with that guided 5mm pilot. It's better than nothing, but that is a great question and it is a limitation. Posterior is very tricky.
But because of the burr designed by the DIO group is you have more vertical opening opportunities than you will with some other companies. The other thing I might suggest is plan for a 7mm implant length, even if you've got room for a 10 or a 15. Who cares, right? Go with a shorter implant necessitating less of a length of burr, and don't plan something in the number 1.5 space towards 2. You know, be happy with an implant in second premolar or molar and then cantilever judiciously to accomplish that. But that's a tough one. It's not going to go away. The human jaw is just never going to open as wide as we want it.
Yeah, plan B is you get your brother oral surgeon to come in, have him remove the mandible so you can place the implant and then have him put it back on. I haven't had anyone accept that yet, but it's always been in the back of my mind as a plan B.
Yeah, and I think that made no sense. That was ridiculous. That would be a lot of surgery.
Thank you. Well, you know, just being creative. So wrapping up, we want to thank you so much for your time. We were about an hour, which is only about twice as long as we wanted to take. So that's not too bad for us.
But I hope you got what you paid for. Okay, I agree. Yeah, you didn't pay anything. So if you didn't get anything out of it, you got what you paid for.
We really appreciate you guys. If there are any questions, reach out to us. We hope that this update was helpful. We will continue to do this to help two things, help support our doctors that have committed to DIO and also help, you know, answer any questions of curiosity about our doctors that haven't heard a lot about DIO. So thank you. Thank you. PK has a few closing words and then we'll end.
I appreciate your attendance, and if our frivolity has been offensive in any way, we apologize. We're just getting tired and we get goofy.
Yeah, PK's goofy. Appreciate you guys. Thank you for your attendance.
My only last remark is always strive to be the dentist your mother thinks you are.
Well, amen to that. On that note, take care, you guys. Have a good one.